Hi, I'm Jen. Today we're going to cover Section I of the MDS. I'm going to use the KISS method. That stands for Keep It Simple, Super Nurse. So if you have any further questions after the video, make sure you visit our website. We have another video there that goes into further detail, and also use your RAI manual. So we're going to discuss Section I and what makes a diagnosis active. The RAI tells us we have two requirements that we must follow in order to code a diagnosis in Section I as active. The first requirement is a physician's signature within a 60-day time frame. So your ARD and then 60 days. If a medical doctor, nurse practitioner, physician assistant, or clinical nurse specialist in some states has signed within the last 60 days that that diagnosis is active, then you have met the first requirement. So getting that physician's signature on the medication administration record, a TAR, a progress note, anywhere that a physician, NP, PA, or clinical nurse specialist has signed and shows that that diagnosis was active in the 60 days, you satisfy that first requirement. The second requirement is an active treatment for the diagnosis during the 7-day look-back period. Per the RAI manual, an active treatment could be a medication for the diagnosis, a nurse's note for the diagnosis, a treatment for the diagnosis, or even a care plan with interventions that we're monitoring for that diagnosis. Those are all things that would make the diagnosis active in your 7 days. So when you're looking for those items to make the diagnosis active, you're going to look at the medication sheet and see, was a medication given for this diagnosis? You're going to look at the treatment sheet and see if a treatment was given, or maybe a nurse wrote a note. One example might be the nurse writes a note that she elevated the head of bed due to shortness of breath while lying flat, due to the diagnosis of COPD. That note would meet the definition of active because we actively did something for that diagnosis in our 7-day look-back period. So that would mean we met the second requirement. So you always have to make sure you meet both requirements, the MD signature and active treatment during that time frame, before you code Section I. There's one exception, and that's a urinary tract infection. It has a 30-day look-back period. So you'll look through those requirements in your 30-day look-back time frame to see if the definition of urinary tract infection has been met, and if you have that MD signature. So you just have to ensure you meet the two requirements before you code a diagnosis on the MDS. Now, for my friends in Indiana and Ohio, you have additional requirements called supportive documentation guidelines. The supportive documentation requirements or guidelines, whichever one you want to call them, require additional documentation to support diagnoses and/or items that we code on the MDS that might impact CMI. So any item that we code on the MDS that has the potential to impact your case mix index, we call ruggable. A ruggable item has potential to increase your CMI, case mix index. So in the state of Indiana and Ohio, we have a separate auditing agency who will come into our facilities to check to make sure we meet the supportive documentation requirements. So the RAI manual gives us the basic rules of the MD signature within a 60-day time frame and an active treatment within the 7-day time frame. So the RAI will accept if we have a care plan in place, that's enough documentation to actually code an active diagnosis. However, If that diagnosis has the potential to impact your CMI, or is known as a ruggable diagnosis, then Myers and Stauffer, the auditing agency, when they come in, they're going to look for documentation that the diagnosis was given an active treatment within the 7-day time frame. So we all know that if it wasn't documented, it wasn't completed. So Myers and Stauffer will not accept the care plan because that is not sufficient documentation for them to support that the treatment was actually given. So if you have a ruggable diagnosis and you do not have a medication or a treatment or a nurse's note to support that it was actively treated during that 7-day time period, then you're going to need to code that diagnosis in I-8000. Typically with I-8000, we code diagnoses that aren't listed above in that section. That section is for active diagnosis, so I-8000 would be a perfect place to code a ruggable diagnosis that you don't have all of the supportive documentation for. So let me give you an example. I have a resident who has COPD. I have my physician's signature within the 60-day time frame, and I have a care plan that says the resident is at risk for complications related to COPD. Intervention, we elevated the head of the bed. So we have that active treatment per the RAI guidelines. But since that diagnosis has a potential to impact our CMI, we do not meet the supportive documentation requirements. So we would need to code that diagnosis of COPD in I-8000. I hope that this video answers all of your questions, but if you have any further questions, make sure and reach out and I'll be happy to get back with you. Go ahead and hit that subscribe button now so you don't miss out on any of our further educational videos. Thanks for learning with Jen, and as always, I hope you have an amazing day.